my name is Amber Goana and I would like to welcome you to my Med Talk. This is going to be some of the things I pulled from the CPJE California law exam, and as you can see, it's going to be basically like a little Naplex, and so each video is just going to go over each section that I kind of pulled little things from, and I hope you like it. So for this section, we're going to be going over some medications that are blood thinners and antiplatelets. There's unfractionated heparin. It binds to antithrombin 3 and thrombin complexes, causing inactivation of factor 2A and 10A. It's dosed 5,000 units sub-Q every 2 hours before surgery, and then every 8 to 12 hours for the next 7 days. That's really for VTE prophylaxis dosing. You can do 80 units per kilogram IV bolus with a max of 10,000 units, and then 18 units per kilogram per hour with a max of 2,000 units per hour, or 5,000 units IV bolus, then 1,000 units every hour for someone who's inpatient and you're trying to treat them for an active VTE. 333 units per kilogram sub-Q for the first dose, and then 250 units per kilogram sub-Q every 12 hours. That's more outpatient treatment for VET. 60 units per kilogram IV bolus with a max of 4,000 units, then 12 units per kilogram per hour with a max of 1,000 units. This is not really recommended to use this regimen over 48 hours. You want to max it out at that, but it's treating acute STEMI. Given unfractionated heparin IV has an immediate onset of action. Sub-Q, it's about 20 to 30 minutes before it's going to take effect. The half-life is 1.5 hours. General precaution, you do not preserve product with benzyl alcohol or administer unfractionated heparin IM because it causes hematoma at the site whenever you inject it. You want to avoid use in patients with thrombocytopenia. 1 milligram of protamine can be used to reverse 100 units of heparin, but the max dose of protamine you want to use is 50 milligrams. Some side effects of unfractionated heparin include HIT, which is going to be a decrease in your platelet count greater than 50%. It can also cause an increase in your liver aminotransferases. So you really just want to monitor their liver function. You want to monitor their APTT every 4 to 6 hours, as well as the patient's platelet count. Next, you have low molecular weight heparin. It works by binding to antithrombin 3, causing a decrease mainly in factor 10, but it does have some effect on factor 2. There's 2 different options here. First up, we have enoxaparin Lovenox. It's dosed 30 milligrams sub-Q every 12 hours after surgery, up to 14 days, or 40 milligrams sub-Q daily, given 2 hours before surgery, and then for 7 to 10 days after that, once a day. Their creatinine clearance, if it's less than 30 milliliters per minute, you kind of want to do a max of 30 milligrams daily sub-Q. This dosing is going to be for DVT prophylaxis. 1 milligram per kilogram sub-Q every 12 hours. You want to monitor that creatinine clearance. Again, if it's less than 30 milliliters per minute, you want to do 1 milligram per kilogram sub-Q daily instead of every 12 hours if you're trying to treat someone with a DVT or unstable angina. 30 milligrams IV bolus, and then 1 milligram per kilogram sub-Q every 12 hours with a max of 100 milligrams for the first 2 doses. Again, if their creatinine clearance is less than 30, you want to do a 30 milligram IV bolus and then 1 milligram per kilogram sub-Q daily instead of every 12 hours. That's really for patients that's less than 75 years old though. 0.75 milligrams per kilogram sub-Q every 12 hours with a max of 75 milligrams for the first 2 doses. Creatinine clearance less than 30 milliliters per minute. You want to do that 1 milligram per kilogram sub-Q daily instead of 12 hours. That's for patients that are greater than 75 years old. Both of these two is going to be for STEMI dosing treatment. The next option you have here is dalteparin fragment. It's 2,500 to 5,000 units sub-Q daily. That's DVT prophylaxis dosing. 120 units per kilogram sub-Q every 12 hours with a max of 10,000 units a dose is for unstable angina dosing. General precautions with low molecular weight heparin. You want to avoid in patients who have a positive antibody test to heparin antiplatelet and have thrombocytopenia. Bacterial endocarditis, if they're having some sort of coronary intervention procedure, they have renal dysfunction, diabetic retinopathy, a past medical history of HIT, or if they're getting an epidural or some sort of spinal procedure, you definitely want to avoid in these patients using low molecular weight heparin because it can cause long-term paralysis. Some side effects include anemia, increased liver function tests, and hematoma. You want to monitor the patient's CBC, platelet count, signs of neurological impairment, their anti-factor 10A level, which is actually not required in most cases, but it is something that you could monitor. Next we have warfarin. It's going to block the regeneration of vitamin K epoxide, causing a decrease of clotting factors 2, 7, 9, and 10, as well as the proteins C and S. It does have a narrow therapeutic index, so you definitely want to monitor their levels. You really kind of monitor the patient by their INR level. Coumadin is another name for it. It's dosed based on INR level. Most INR target goals are going to range from 2 to 3. If the patient has a mechanical mitral valve, their INR goal is going to be 2.5 to 3.5. It can be started the same day someone is put on unfractionated heparin or low molecular weight heparin and continued for 5 days or until their INR is greater than or equal to 2 for at least 24 hours. And then you want to DC that other medication, whether it's heparin or low molecular weight heparin. General precautions include it takes 6 days for pharmacological effects. The S isomer of warfarin, which is going to affect 2C9, is actually 5 times more potent than the R isomer. The R isomer really affects 3A4. You want to avoid mango and liver containing products for people who are on warfarin because it just increases their risk of bleeding. Pregnant women, unless they have a heart valve, you really don't want to use warfarin in them. If a patient has bacterial endocarditis or a past medical history of HIT, you would also want to avoid use with amiodarone and NSAIDs. Consider testing the patient for 2C9 and VKORC1 variations. Vitamin K is used as an antidote to help reverse warfarin. Side effects include purple toe syndrome, alopecia, so you could lose some hair, and tissue necrosis. You want to monitor the patient's INR, hemoglobin, hematocrit, gangrene, signs of bleeding. Next we have direct thrombin inhibitors. They directly inhibit thrombin, causing a decrease in fibrin available for clot formation. We have 3 options here. Dabigatran Pradaxa. It's 150 milligrams twice a day. What you actually want to avoid use if the patient's creatinine clearance is less than 30 milliliters per minute. This is dosing for DVT and PE treatment as well as prophylaxis dosing. It has the same dosing. 110 milligrams 1 to 4 hours after surgery, and then you want to do 220 milligrams daily for 28 to 35 days, depending on if it's a hip or knee replacement. 150 milligrams twice a day is going to be used for non-valvular AFib prophylaxis, but if their creatinine clearance is 15 to 30, you want to do 75 milligrams twice a day instead of 150. This medication, dabigatran, is a P-glycoprotein substrate, so you want to avoid use with dexamethasone. Praxabind is the antidote for Pradaxa. It is known to increase PT and INR as well as APPT levels. Take the dose if it's missed by less than 6 hours, otherwise skip it. So if your patient kind of forgets to take their dose and it's been less than 6 hours, they want to go ahead and take that dose. But if it's been more than 6 hours, you don't really want to double up really close to the next dose. You need to store in the original bottle and discard 4 months after you open it. So you don't want to be putting this in another container whenever you're preparing these medications for the patients to take home at your pharmacy. Next option here we have adregatroban. It's 2 micrograms per kilogram per minute until the APPT is 1.5 to 3 times the initial baseline, but not to exceed 100 seconds. The max dose is going to be 10 micrograms per kilogram per minute. This is HIT dosing treatment. 350 micrograms per kilogram bolus with 25 micrograms per kilogram per minute is PCI treatment dosing. 1 milligram per kilogram sub-Q every 8 hours is for knee or hip replacement DVT prophylaxis. This adregatroban can be used in patients with a history of HIT. It will require hepatic adjustment. It can cause an increase in INR levels as well. Bidarudin, a Geomax, it's 0.75 milligrams per kilogram IV bolus, and then 1.75 milligrams per kilogram per hour. That's if their creatinine clearance is less than 30. If it's greater than 30, you actually want to reduce the infusion rate to 1 milligram per kilogram per hour. And this is dosing for HIT and PCI. It is good for use in patients with ACS. And whenever it talks about PCI dosing and ACS, it's just like coronary artery disease, so some sort of buildup around your arteries is causing your blood flow to be a little bit not that great. Some general precautions with these direct thrombin inhibitors: you want to avoid use with epidurals or spinal procedures because of that long-term paralysis. Patients with prosthetic heart valves, and that's mainly for dabigatran, you would want to avoid. Side effect wise, these can cause esophagitis, gastritis, GERD, chest pain, hypotension, and headache. Heartburn is kind of also seen with dabigatran. Monitoring is including the renal function, serum creatinine, their APTT levels, hemoglobin, as well as hematocrit. Next we have some direct factor 10 inhibitors, and these are actually pretty great because they're not going to require any sort of monitoring routinely. We have apixaban Eliquis, 2.5 milligrams twice a day, starting 12 to 24 hours after surgery for 12 days. It's for a knee or hip replacement, prophylaxis DVT dosing. 10 milligrams twice a day for 7 days, and then 5 milligrams twice a day is going to be treatment for an actual DVT or PE. 2.5 milligrams twice a day for at least 6 months is going to be for recurrent DVTs and PE treatment. 5 milligrams twice a day or 2.5 milligrams twice a day. And this is if they have 2 of at least 3 of the following. They're either 80 years old or older, they have a body weight of less than or equal to 60 kilograms, or their serum creatinine is either 1.5 milligrams per deciliter or higher. If they have two of those qualities, they can do 2.5 milligrams twice a day, and this is non-valvular AFib dosing. You would want to make sure the patient is taken off warfarin and start Eliquis after the INR level is less than 2. Premature taking off the medication with patients who are trying to switch over from warfarin is going to increase the risk of thrombotic events. DC in the med 48 to 24 hours before the procedure is a must. You got to make sure you're doing that. Eliquis is a major 3A4 and a P glycoprotein substrate. Next we have rivaroxaban Exarelto. It's 10 milligrams daily starting 6 to 10 hours after surgery for 12 days if it's a knee replacement, but 35 days if it's a hip replacement. And this is for DVT postoperative prophylaxis. 15 milligrams daily with food for 21 days, then 20 milligrams daily is going to be for DVT PE treatment dosing. 20 milligrams daily with food is going to be for recurrent DVT PE prophylaxis dosing. If the patient has creatinine clearance less than 15 milliliters per minute, you want to avoid the use of Exarelto. The patient can do 20 milligrams daily with the evening meal as long as their creatinine clearance is greater than 50, but if it's less than 50, you want to max it at 15 milligrams daily, and this is for non-valvular AFib prophylaxis dosing. Again, premature discontinuation of this medication is going to increase thrombotic events. So if you're not doing it exactly for the 12, 35, you got to be very, very careful that they're taking it for the appropriate amount of time. You want to make sure you DC warfarin and you start Exarelto when the INR level is less than 3. So for Eliquis, it had to be less than 2, but for Exarelto, it can be less than 3. You want to make sure the patient discontinues medications 24 hours before a procedure. So with Eliquis, it was 48 to 24 hours. With Exarelto, it's 24 hours. Just like Eliquis, it is a major 3A4 and P glycoprotein substrate. Last up here we have endoxaban Saviza. It's 30 milligrams daily starting 6 to 24 hours after surgery for 11 to 14 days. It's a hip or knee DVT prophylaxis dosing. 60 milligrams daily starting 5 to 10 days after the patient has been on IV anticoagulants is going to be for DVT PE treatment dosing. 60 milligrams daily is for non-valvular AFib prophylaxis dosing. You want to avoid use in creatinine clearance greater than 95 milliliters per minute because this is actually going to increase the risk of ischemic stroke. If their creatinine clearance is between 15 and 50, you kind of want to max them out at 30 milligrams daily. But if it's less than 15, you want to avoid use at all in this patient. It is known to cause a rash and elevate liver enzymes. You want to make sure you DC warfarin and start Silvaza when the INR level is less than 2.5. So Eliquis, it had to be less than 2, Exarelto less than 3, but Silvaza less than 2.5. If you're trying to switch the patient from Silvaza to warfarin, you want to half the dose of Silvaza and start warfarin. You can DC Silvaza after the INR level is greater than 2. If a patient is getting ready to have a procedure, you want to make sure you stop taking this medication 24 hours before the procedure, just like Exarelto. This is a P glycoprotein substrate. You want to avoid use with dexamethasone. General precautions with these direct factor 10A inhibitors. You want to avoid use in epidural spinal procedures because of that paralysis. Patients that have prosthetic heart valves, mitral stenosis, and severe hepatic impairment. You want to make sure you're avoiding use in those patients. These drugs can actually be crushed and placed in 2 to 3 ounces of water or applesauce if they're consumed immediately. Side effects include hemorrhage, hematoma, and anemia. You want to monitor hemoglobin, hematocrit, liver function tests, serum creatinine, and neurological impairment. There's one indirect factor 10A inhibitor, selectively inhibits factor 10A via antithrombin 3, so it's not directly, it kind of works through antithrombin 3. It's fondaparinux, Atarax. It's 2.5 milligrams sub-Q daily, every 6 to 8 hours for knee, but it's going to be every 24 hours for hip post-op for at least 10 to 14 days. You do not want to use in patients who are less than 50 kilograms or if they have a creatinine clearance less than 30 milliliters per minute. And again, this is for hip and knee DVT prophylaxis dosing. It can be used in VTE treatment whenever the patient weighs more than 50 kilograms per minute. But it's going to be a little bit varying of the dose for treatment. So if they're less than 50 kilograms, you want to do 5 milligrams sub-Q daily. If they're between 50 and 100 kilograms, it's 7.5 milligrams sub-Q daily. Greater than 100 kilograms, 10 milligrams sub-Q daily for 5 to 9 days. That's a VTE treatment. General precautions: avoid use with epidurals, spinal procedures because of that paralysis. It can cause bacterial endocarditis. Patients who have positive antibody tests to fondaparinux antiplatelet, and if they have thrombocytopenia. You want to avoid use in all those patients. It could cause a rash, injection site reactions, edema, thrombocytopenia, hematoma, as well as hypokalemia. So fondaparinux can actually lower your potassium levels. Next we have P2Y12 inhibitors. They bind to platelets on their adenosine bisphosphate P2Y12, which is going to prevent GP2B3A receptor complex activation. Examples we got: clopidogrel, Plavix, 300 milligrams, and this is going to be for ACS, MI, and stroke. Loading dose, and then 75 milligrams daily. Or it's going to be 600 milligrams for PCI loading dose, and then 75 milligrams daily. If your patient is greater than 75 years old and they are receiving a fibrinolytic agent, you don't really need a loading dose of Plavix. It is a prodrug and it is activated by CYP2C19. You want to make sure the patient discontinues the medication 5 days before elective surgeries. So remember, the other ones were within so many hours of the surgery. Plavix is 5 days before the surgery. We got Pasigrel Effient. It's 60 milligrams by mouth loading dose, and then 1 hour after the PCI, and then you can do 10 milligrams daily. If the patient is greater than 75 years old, or if they weigh less than 60 kilograms and they're on aspirin at least 100 milligrams a day, you can actually do 30 milligrams on them, followed by 10 to 5 milligrams daily. And this is going to be for ACS prophylaxis dosing. Known to have more risk of bleeding compared to Plavix, it needs to be kept in the original container. So whenever you're filling the prescriptions for Effient for patients in your pharmacy, you want to keep it in that original container. It is a prodrug, just like Plavix. It is known to cause thrombocytopenia purpura. Next we have Tigrelor, Brilinta. It's 180 milligrams by mouth loading dose, and then 90 milligrams twice a day starting 12 hours after that loading dose for 1 whole year. Then you want to do 60 milligrams twice a day on after that. This is if a patient has ACS and they are treating this with Brilinta. It is the preferred agent to use in medical management as well as with PCIs. It is known to cause bradyarrhythmias, increase serum creatinine, as well as uric acid. So if your patient has gout, that's something you want to be aware of with Brilinta, because it can also increase their uric acid levels. Again, you want to make sure you DC the med 5 days before elective surgeries, just like Plavix. It can be crushed and mixed in with water. Last option we got here is Cangrelor, Cangrel. It's 30 micrograms per kilogram IV, bolus given prior to the PCI, and then you can do 4 milligrams per kilogram per minute for 2 hours, or the duration of the procedure, whichever is longer. This is going to be an adjunct to PCI dosing. So the Brilinta, Effient, and Plavix were all by mouth, and this Cangrelor is more of an IV, something they're going to receive whenever they're actually getting treated for a PCI. General precautions with these P2Y12 inhibitors: you do not use if the patient is undergoing CABG, which is some sort of blood flow that's going to the heart and they're having an operation to fix that. You do not want the patient to be using this. You want to GC it 7 days instead of 5 days before elective surgeries. It's going to be 7 days. Premature discontinuation of the medication could increase the risk of thrombotic events, just like the other ones we were talking about. Side effects include hematoma and hepatotoxicity. Next, we got glycoprotein 2B3A receptor antagonists. They bind to the receptor, which prevent fibrogen, von Willebrand factor, and victorectin from binding to this 2B3A receptor. There's acimimab, Ripro. It's 2.5 milligrams per kilogram IV bolus, and then 0.125 micrograms per kilogram per minute for 12 hours, with a max of 10 micrograms per minute. This is for PCI or STEMI with PCI dosing. We have 0.125 micrograms per kilogram per minute for 18 to 24 hours with a max of 10 again. That's for NSTEMI ACS unresponsive therapy to the PCI within 24 hours of dosing. It is known to cause thrombocytopenia. You want to avoid in patients with intracranial neuroplasm, arteriovenous malformation, or inertium, which is where your artery is kind of ballooning and it's kind of weakening. Whenever this Repro binds, it's actually irreversible blocking. It cannot be reversed. It does need to be administered with a filter needle when compounding or administering. Eptipodide antigrelin is 180 micrograms per kilogram IV bolus with a max of 22.6 milligrams. This is times 2, and this is going to be if the patient is PCI. Then you want to do 2 micrograms per kilogram per minute with a max of 15 micrograms per hour. And this is going to be for 18 to 24 hours after PCI. If the patient actually has no PCI, you would only want to do it for 12 to 72 hours. If their creatinine clearance is less than 50 milliliters per minute, you want to reduce the maintenance dose to 1 microgram per kilogram per minute with a max of 7.5 milligrams per hour. It is known to cause hypotension, so just be aware that your patient's blood pressure could be lowered whenever you're giving them IV antigrelin. Lastly, we have trophibin aggrostat. It's 25 micrograms per kilogram IV bolus within 5 minutes. Then it's 0.15 micrograms per kilogram per minute, and this is only if the creatinine clearance is greater than 60. If it's less than or equal to 60, you're going to do 0.075 micrograms per minute after that bolus of 25 micrograms per kilogram. This is only used whenever the patient has an ACS or PCI or non-STEMI dosing. You want to avoid in patients who are undergoing renal dialysis, this aggrastat. General precautions with all these 2B3A4 receptor antagonists: you want to avoid an uncontrolled hypertension, surgery or trauma within 6 weeks, or if their platelet count is less than 100,000, or they have vasculitis. Some side effects include chest pain and backache. You want to monitor the patient's hemoglobin, hematocrit, platelet count, serum creatinine, prothrombin time, but that's mainly for the axatilimab, which was the first one, the repro that we talked about. You want to monitor the prothrombin time because it is really irreversible, so it's kind of super important to really monitor those patients. The last section I got here is fibrinolytic agents, also known as tissue plasminogen activator, TPAs. They work by converting plasminogen to plasmin, causing fibrin to break down, leading to the dissolving of clots. Alteplase activase is one option. It's 15 milligrams IV bolus and then 50 milligrams IV infusion over 30 minutes. Then you want to do 35 milligrams IV infused for 1 hour for the patient if they are greater than 67 kilograms. But if they're less than that, you're going to want to do 15 milligrams IV bolus, then a 0.75 milligram per kilogram IV infused over 30 minutes, and then 0.5 milligrams per kilogram infused over an hour if they're less than 60 kilograms. This is for acute MI dosing. The max of this is going to be 100 milligrams, and you want to avoid use in ischemic stroke. Next we have rectaplase retavase. It's 10 units IV infused over 2 minutes, and you want to repeat the dose in 30 minutes, again for acute MI dosing. Then we have tenecteplase TNNcase. It's 30 milligrams IV bolus for patients less than 60 kilograms. If it's 60 to 69 kilograms, it's going to be 35 milligrams. And if it's 70 to 79 kilograms, it's 40 milligrams. 80 to 89 kilograms is 45 kilograms. But if the patient weighs more than 90 kilograms, it's going to be 50 milligrams IV bolus. And again, this is for acute MI dosing. So alteplase, renectaplase, tenecteplase, all of them are going to be really for MIs. General precaution: they need to be started within 30 minutes of the arrival of the patient to the hospital. You want to avoid use if the patient is actively bleeding, they have an intracranial hemorrhage, they are going to have intracranial or intraspinal surgery, serious head trauma in the past 3 months, they have hypertension, subarachnoid hemorrhage. All of those patients you kind of need to avoid use. Some side effects include bloating, cerebral herniation, intracranial bleeding, ischemic stroke, seizures, and cardiovascular accidents. Some monitoring you can do on these patients: you need to watch their hemoglobin, hematocrit, their blood pressure, and signs of bleeding. So as you can see, the dosing is like all over the place with a lot of these agents. You really need to make sure that you're dosing them appropriately. So honestly, whenever you have a patient come in with something like this, you need to be looking up and making sure you're getting the correct dose. Again, my name is Amber Gawana, and I wish you the absolute best in all of your studies. For real, you got this.